coronary syndrome associated with this. This final movements that diminished movement can be determined by this SOHO test that it is measured the fixed spinal segment in standing position and in flexion. The diminished movement, if it is movement is less than 10 centimeter, then there is a chance of ankylosing spondylitis. We should know about it. Now, radiological picture that we see in ankylosing spondylitis, this is the typical picture that we see. That is also known as bamboo spine. This is because the syndesmophyte spine adjacent the vertebra and it fused with adjacent vertebra, and it looks like the segment of bamboo. Probably this ankylosing spondylitis, it involves the sacroiliac joint where there is pain, but later the fusion, that is ankylosis with disruption of the sacroiliac joint. At the same time, in vertebra, there is the typical features that we see, that is squaring of the vertebra, such that the lining of the vertebra is sharpened, so it looks like a square. And in this, we see there is these are the intervertebral ligaments that are inflamed, then band, and after that it gets fused. In peripheral joints, there is arthritis and bony ankylosis. This usually involves the knee, but it spares the ankle. Now, differential diagnosis. The most common differential diagnosis that we see in this case of ankylosing spondylitis is mechanical low back pain. So it may be confused with low back pain, so we should know it and we should differentiate it from pain. In low back pain, it is relieved by rest, but in ankylosing spondylitis, it is aggravated by rest. So this is the differentiating features that we see. At the same time, in the morning, in ankylosing spondylitis, but in this low back pain, it is not seen. Other is spondylolisthesis, patient joint instability, and disc disorders that is also to be excluded in case of ankylosing spondylitis. Other is ankylosing hyperosteosis. This is the disorder that we see in case of old age due to hyperosteophytes. And it is also known as forester's disease because there is like, it forms like a forest, that is a dense protuberance of the osteophytes. And this is usually seen in old age and of lumbar and sacral region, but thoracic and cervical region is usually spared. Seronegative arthritis that we see is Reiter's disease, psoriatic arthritis, and enteropathies. These should be excluded. So we should know about it thoroughly. Now, coming to the treatment part, that is how we treat it. This is the disorder due to disorder, so we cannot be treated as such, but we can help the patients to improve the day-to-day life activities. So what we do is we relieve the pain, we relieve stiffness, and we relieve the deformity. So the principle that we follow, for pain we can give analgesics and steroids, and for patients should remain active. And for deformities, for need surgeries. Depending upon the size is involved, if it is fine, then it needs corrective osteotomy with the maintenance of posture. At the same time, if it is hip, we can do the total hip arthroplasty. Now, coming to general measures that we follow for ankylosing spondylitis, and this is most commonly followed, is to encourage the patient to remain active and maintain the posture. Because what the posture patient maintains, the patient may land up in the same posture for long duration, and there is tendency stiffness. So to maintain the normal posture at the same time remain active. And so while we remain active, there is activity of the joint, so there is no we should remain active. And the activities that is helping active is gymnastics, swimming, and stretching exercise like yoga. It helps to maintain the prevent the ankylosis as such. So rest is contraindicated because it aggravates the at the same time it is the cause for the ankylosis. Other is physiotherapy for the chest expansion because chest expansion is also restricted in this case. So we should do deep breathing exercise in and out and extension exercise for deformity prevention. The thing is that as such we pain relief medications, that is NSAIDs, that is for pain. Indomethacins, this is also NSAIDs, but it has a particular activity regarding the bone and calcification. So, we need to do is indomethacin is prescribed in daily basis, but it has a certain drawbacks regarding this gastritis and peptic. Other is DMRs, that is used in the rheumatoid arthritis, and it is also used with the ankylosing spondylitis. This peripheral arthritis we use the sulfasalazine. Sometimes we'll go for the articular corticosteroids because steroids is more potent drug in case of ankylosing spondylitis. Other is low dose radiotherapy. This prevents this again ankylosis, but it has a risk of leukemia. Now surgery, that as we discussed earlier, surgery is usually reserved for the certain procedures. Surgery is usually indicated in case if there is hip, there is total hip joint replacement in case of hip, or sometimes the excision, that is we do the procedure in case of hip, that is total hip replacement, total hip arthroplasty. So this is the arthroplasty. Sometimes we do the excision, or sometimes we need to correct the deformity in case of ankylosing spondylitis. Other is if the joint is non-functional, then we'll go for the arthrodesis, and it helps in better performance in young adults because arthrodesis is most commonly tolerated by the young people, so we do the arthrodesis. And this completes the seronegative arthritis, this ankylosing spondylitis. And now we'll go for the crystal deposition disease, and in it we'll discuss about the gout. Now, crystal deposition disease, it is a group of conditions in which there is presence of crystal in or around joint and bursa and tendons. This is most commonly seen with gout, and gout is caused by usually monosodium urate monohydrate. Urate crystal associated with the purine metabolism. Other is calcium pyrophosphate dihydrate. This is also caused by the CPPD. Other is hydroxyapatite crystal deposition disease. This is due to the hydroxyapatite deposition that is usually formed in bone, but if it occurs outside the bone, in muscles and joints, then we'll get this disease. And this is the consequence of crystal depositions, and it has certain phases that we see in day-to-day life. That is, it remains inert and asymptomatic in first phase, but after some time, it forms synovitis, and it results from the acute inflammatory reactions. And at third stage, there is destruction. So slow destruction of the joint and affected tissue, resulting into a deformity and destruction of the joint. Now, gout. This is exclusive caused by the purine metabolisms, and it is most commonly seen in male. It has a ratio 20 times common in male than females. And if it occurs in females, it is usually after menopause, because estrogen has certain protective effect regarding the gout. Other is hyperuricemia, that is monosodium monohydrate crystal that is deposited, that is excreted in urine. So when it is excreted in urine, there is a chance of deposition of urate crystal in the kidneys. So there is again chance of kidney stones with the hyperuricemia. Other presentation that we see is the recurrent acute synovitis, because gout usually mimic the acute septic arthritis. So there is recurrent episode of synovitis resulting in acute synovitis, and it mimics the acute septic arthritis, and it is usually the emergency conditions. But in this case, this is not as emergency because it relieves by the medications. Now, this your hyperuricemia, it is usually occurs, that is gout occurs by the two mechanisms, usually that is primary and secondary. In primary, 95% of the cases occurs as a primary and it is inherited disorders. It is either due to the overproduction or underexpression of the uric acid. So such that the urate load is high in case of the body in case of primary. And it is inherited disorder due to the defect in metabolism or certain kind of enzymes. Second type is secondary, that is acquired conditions. And in acquired conditions, it is either due to myeloproliferative disorders, and this is due to the overproduction, which cannot be excreted, and it remains in body and present as a gout. And in case of renal failure, there is underexcretion, so that it is again retained in the body, and it occurs and present as a gout. Now, all the thing that you need to know or that we need to know regarding this gout is all the patients with high uric acid does not develop gout. But this is a certain procedure that runs across a year so that crystal is deposited in minute clumps and remain inert for the years. But sometimes there is a local trauma or there is a stress or there is surgery. This results in dispersion of crystal into the joint, which provokes the acute inflammatory reaction and presents as active septic arthritis. After the local trauma, due to dispersion of crystal into the joint, then phagocytes are recruited and or they free float into the joints, such that this results in the inflammatory reactions. Over years, the urate deposits up into the joint and in periarticular tissue, tendons, and fossa. This results in destruction of the articular cartilage and periarticular bone, which is the clinical presentation that we see in day-to-day life. Now, common pathology that we see is the most common site of crystal deposition is metatarsophalangeal joint of the greater toe, Achilles tendon, olecranon bursa, and pinnas of the ear. Tophi is this is potassious material that is deposited in this gout patient is tophi, and it may ulcerate through the skin, and it is present as the white, chalky white materials that comes out of the joints. Now, clinical features, again, it is common in males, but after 40 years of age, and if it is female, usually the menopause, and there is associated features that is obesity, hypertension, and alcohol usually results into the high chance of gout. Sometimes with diabetics, this hydrochlorothiazide, there is a chance of gout. So it is also associated with antihypertension. And if there is a family history, again, there is a chance of gout. In gout, there is sudden severe pain. It is precipitated by the minor trauma or surgery or unaccustomed exercise. So there is a pain. It is more at night and lasts to 1 to 2 weeks, and it completely resolves after that. And in acute gout, what we see is the sites, as we discussed earlier, that is first metatarsophalangeal joint, Achilles tendon. There is these are commonly the site affected, and it is hot and tender. So there is a typical features that is such that skin is red, there is severe tenderness, and local rise of temperature is seen. But hyperuricemia is not always a diagnostic, but since we see the urate crystal in urine is negatively birefringent in polarized light, and it is a confirmed diagnostic for the acute gout. In chronic gout, this is if acute gout may pass into chronic gout, then there is a recurring attacks, and there is increased stiffness because of the joint destruction and deformity. Sometimes there may be profile occurs at the common site as we discussed. There's metatarsophalangeal joint, pinna, and elbow. The large trophy usually ulcerate and discharge salt white materials. And sometimes there is a renal calculi, and renal parenchymal disease is presented as renal failure. Now, coming to the radiology. In radiology, there is only soft tissue swelling in case of acute gout because it is a synovitis. There is no destruction of the adjacent joint. But in chronic gout, there is trophy appear as pontical lesions or cysts in paraarticular bone ends. And this results into the secondary osteoarthritic changes. coming to differential diagnosis, as we discussed, infection it should be differentiated from cellulitis, septic arthritis, and infective bursitis. Sometimes writer's disease should be excluded, but there is a history of protraction, so we should seek the history for writer's disease that is associated from gonorrhea. And the differential features that we see in this case is it is responsive to NSAIDs, but writer's disease is not responsive as such as gout. Now, sometimes pseudogout, it should be differentiated, and this gout affects the smaller joints, whereas pseudogout affects the larger joint, and it is more common in women, and it is due to the pyrophosphate dihydrogenase crystal deposition. In case of rheumatoid arthritis, it is polyarticular gout usually affecting the fingers. Elbow tophi is usually mistaken for subcutaneous nodule, so biopsy helps in diagnosis of the rheumatoid arthritis and gout. Now, treatment. In case of treatment, what we do is in acute stage, we need to rest. Sometimes stent is applied. We need to give this anti-inflammatory NSAIDs, but colchicine was previously used, but is less effective. Other is intra-articular hydrocortisone. It is usually effective, and sometimes the aspiration because there is inflammation, synovitis. So to relieve the pain or this pain due to the effusion, we do the aspiration. Other thing that need to follow is interval therapy. That is usually indicated after acute attacks that occurs at frequent interval, and usually there is presence of tophi and renal function is derailed. So what we need to do is we need to lose the weight because overweight or obesity might be the cause for the gout, and we reduce the alcohol because alcohol is also cause for the gout. Eliminates the certain diuretics causing the gout, and we sometimes prescribe the uricosuric drops, that is allopurinol, that is xanthine oxidase inhibitor. That is in interval therapy, we use uricosuric drops if renal function is normal, because it should be excreted through the urine, so urine function should be normal. Otherwise, we need to go for other drops. Well, that is xanthine oxidase inhibitor is preferred, but these are the never acute stage drop because it precipitates the gout as such with treatment. So there is a chance of acute arthritis after the allopurinol. So we should always give NSAIDs or colchicine to prevent the attack of acute gout. That is, it is prevented by these NSAIDs and colchicines. So allopurinol is always given with NSAIDs or colchicine. In chronic gout, again, allopurinol is drop of size, and sometimes there is ulcerating profile. It may need to be given. Okay. Thank you for the class.
Thank you, sir. Thank you, sir. Thank you, sir.
Welcome. Good day.